Hello everyone and welcome to our module on muscle disorders. Let's start by talking about polymyalgia rheumatica. This is an inflammatory disorder, and this is an important point to remember because, as we'll talk about in a minute, in this disorder, blood levels of CRP and the erythrocyte sedimentation rate are elevated, and that's because inflammation is involved. The cause is unknown. This is a disease of older patients. The typical age is over 50, and many patients I treat who have this disorder are in their 70s or 80s. The main symptoms are muscle pain and stiffness, and we'll talk more about that in a minute. And this is a disorder that is diagnosed clinically. There's no pathognomonic test. There's no biopsy specimen you need to be aware of. Basically, if the patient has the classic symptoms and signs of inflammation, that's how you make the disorder. And a very high-yield thing for you to know about polymyalgia rheumatica is that it commonly occurs together with temporal arteritis. In the immunology section in the video on vasculitis syndromes, I talk about temporal arteritis, which involves inflammation of the temporal artery that can lead to headaches and blindness. So many patients who have temporal arteritis also have polymyalgia rheumatica. The two disorders classically go together. The symptoms of polymyalgia rheumatica are bilateral proximal muscle stiffness. So first of all, the symptoms are bilateral. If a patient says just one joint like the shoulder or the hip is involved, they are probably talking about something else. In addition, the muscle groups that are involved are the proximal muscles. So these are the muscles highlighted in this image on the screen here. This includes the neck and torso, the shoulders and proximal arms, and the hip and proximal thighs. And then finally, the main complaint patients have in this disorder is stiffness. It's not a disorder of muscle damage and muscle weakness. It's that the joints feel stiff, and it makes it difficult for the patient to use the joints when they want to. The symptoms are classically worse in the morning, so patients in a board question will classically describe difficulty dressing, for example, difficulty combing their hair. These are things we all do in the morning that will require us to use our shoulders and our hips. As I mentioned before, polymyalgia rheumatica does not cause muscle weakness. This is a disorder of inflammation of the joints and the membrane surrounding tendons, so it leads to what patients describe as muscle symptoms, but actually the muscles are not inflamed and are not damaged, and that distinguishes this disorder from myositis, which we're going to talk about later on. So especially in terms of board questions, if they are describing polymyalgia rheumatica, strength testing will be normal, and the creatinine kinase level will also be normal because there is no muscle damage occurring in polymyalgia rheumatica. Patients may complain of muscle pain and myalgias, especially in the shoulder. This is a classic complaint, but remember what I said before, the strength testing will show that the shoulder is normal and the CK level will be normal. And then in addition, because this is an inflammatory disorder, patients can sometimes have generalized symptoms of inflammation like malaise, fever, and fatigue. So the way you diagnose polymyalgia rheumatica is by identifying the characteristic clinical features. Remember, it's largely going to be a complaint of muscle soreness and stiffness, but not weakness. On blood testing, the CRP level and the ESR level will be increased. And then in addition, you should know that this disorder, because it's inflammatory, responds very well to glucocorticoids. In fact, symptoms usually completely resolve. And this is sometimes a trick used clinically. If a patient has diffuse muscle stiffness, you can administer glucocorticoids as a trial. If the symptoms completely go away, then you know you are likely dealing with a case of polymyalgia rheumatica. Next disorder we'll talk about is fibromyalgia. This is a chronic pain disorder where patients develop widespread musculoskeletal pain. It's common in young women, usually 20 to 55 years of age, and about 30 to 50% of patients have a coexistent diagnosis of depression and anxiety. So especially in a board question, this will be a young woman who has known depression or anxiety who then develops musculoskeletal pain. The cause is unknown and it's diagnosed clinically. There's no muscle biopsy findings. If you do a muscle biopsy on patients with fibromyalgia, it will be normal, and all the lab tests will be normal, including the SED rate, the CRP level, and the CK level. Women who have this disorder usually complain of diffuse musculoskeletal pain that comes and goes. On examination, they classically have point tenderness, usually in specific anatomic locations. Shown on the screen here are some of the classic trigger points for fibromyalgia. If you press on these areas during the examination, you can often elicit pain in patients with fibromyalgia. Fibromyalgia is relatively common. You will see many patients with this disorder in clinical practice. Unfortunately, we really have a poor understanding of the disorder and we don't have very good treatment options. Some of the things that have been shown to be effective are exercise, and especially in a board question, one of the first things you want to recommend to a patient with fibromyalgia is to stay active. In addition, there is some evidence that tricyclic antidepressants, especially amitriptyline, may help, and also SSRIs. For the remainder of this module, I'm going to talk about the inflammatory myopathies. These are autoimmune muscle disorders that involve muscle inflammation, and the two major disorders in this class that you should know for the Step 1 board exam are polymyositis and dermatomyositis. They classically involve skeletal muscle and therefore present with weakness, although you should be aware that they can sometimes involve the heart and lead to myocarditis and decreased myocardial function. In both of the myopathies we'll talk about, dermatomyositis and polymyositis, the key test for diagnosis is a muscle biopsy. They both have classic findings on muscle biopsy that I'll show you in a few slides. And then because these are inflammatory conditions, the mainstay of treatment is immunosuppression. So when a patient presents with muscle weakness from muscle inflammation from one of these disorders, usually corticosteroids like prednisone are started, and that makes the symptoms go away. And then long-term, they are treated with a steroid-sparing agent. These are drugs like azathioprine or methotrexate that also suppress inflammation, but spare the patients from the side effects of long-term steroids. There are classic muscle features of both of the inflammatory myopathies we're going to talk about in a minute that you need to be aware of so you can recognize these in a board question. So first of all, patients with an inflammatory myopathy will complain of muscle pains, which is myalgias. In addition, they will report the slow onset of progressive symmetric muscle weakness. And remember, it's symmetric, so if they just say one arm or one leg is weak, then they're talking about some other disorder. If they say both arms and both legs are weak, then they may be talking about an inflammatory myopathy. The hallmark is that the disorder begins with proximal muscle weakness. So the proximal muscles are the muscles closest to the midline. These are the same muscle groups that are affected in polymyalgia rheumatica, but remember, in polymyalgia rheumatica, there is no muscle weakness and no muscle inflammation. That's how you can distinguish the inflammatory myopathies from PMR. So when patients have weakness of the proximal muscles, they will have difficulty doing things that involve the hips and arms. So it'll be hard to rise from a chair. It'll be hard to lift the legs to climb stairs. Another classic complaint is that patients can't comb their hair. That's because you have to raise your arm over your head to comb your hair. The fine hand movements, however, will be intact, so patients will be able to grip things normally, at least in the initial stages of the disorder. If it goes untreated for a long period of time, then distal muscle weakness can occur, but that happens late in the disease. There are also some common laboratory findings that you can see in both dermatomyositis and polymyositis. First of all, in both disorders, there is an elevated creatine kinase level. That's because there is ongoing inflammation of muscle tissue and muscle cells are spilling CK into the serum. The ESR can be elevated because these are inflammatory disorders, although this is not a reliable marker because sometimes it can be normal. Antinuclear antibodies, or ANAs, are also typically abnormal in the inflammatory myopathies. Now, these can be elevated in lupus and other autoimmune disorders. An elevated ANA level is not specific for the myopathies, but it is positive in 80 to 90% of patients. And then there are a couple of very strange antibodies that you should be aware of for the inflammatory myopathies, and the one you always want to remember is anti-Jo1. This is an antibody directed against a cellular enzyme called histidyl tRNA synthetase, and it's the most commonly abnormal antibody in myositis. And then there are a couple of other strange antibodies like anti-MI2 and anti-SRP that can also be abnormal, but the one you definitely want to remember for your board exams is anti-Jo1. To understand the biopsy findings in polymyositis and dermatomyositis, we need to review a little bit of the terminology of skeletal muscle tissue. So if you look at this picture on the screen here, we've got a bone, and then we've got a tendon, and then we've got a skeletal muscle here. So the skeletal muscle is made up of muscle cells or myocytes. They're also called muscle fibers. This is one right here. And surrounding each individual fiber is a layer of connective tissue called the endomysium. That's connective tissue surrounding each muscle fiber. However, the muscle fibers are bundled together in these fascicles of a whole bunch of them together, and then each fascicle is surrounded by a membrane called the perimysium. And then the muscle itself is made up of multiple fascicles all surrounded by a layer called the epimysium. But in terms of understanding the inflammatory myopathies, as we'll see, they can have inflammation involving either the perimysium or the endomysium, and that's what distinguishes the disorders. In polymyositis, the classic finding is endomysial inflammation. So remember, the endomysium surrounds an individual muscle fiber or cell. So if you look at this biopsy on the screen here, we've got a muscle cell right here, and there are inflammatory cells surrounding it. That is inflammation of the endomysium, the hallmark of polymyositis. And when you study the inflammatory cells, the predominant cell type in polymyositis is CD8 positive T cells. And so now let's talk about dermatomyositis, which has the same muscle symptoms as polymyositis, slow onset proximal muscle weakness. The distinction between dermatomyositis and polymyositis is that in dermatomyositis, as the name implies, there are skin changes, and it is also diagnosed by characteristic findings on muscle biopsy. So in a muscle biopsy in dermatomyositis, what you see is perimysial inflammation. This is shown on the screen here. So here we've got a whole bunch of muscle fibers, and the inflammatory cells are outside that bundle of muscle fibers involving the perimysium. That is classic for dermatomyositis. And the characteristic cell type here, in contrast to polymyositis, is CD4 positive T cells. There are many skin findings that can occur in dermatomyositis, but there are two classic ones that you should know. The first one is called a heliotrope rash. A heliotrope is a purple plant, so a heliotrope rash is a purple discoloration of the skin. It classically occurs on the upper eyelids. On the bottom right side of the screen is a patient with dermatomyositis who has a heliotrope rash on the eyelid. Second classic finding is the presence of Gottron papules. These are symmetric red scaly papules that occur on the hand and finger joints. They're symmetric, so you'll see them on both hands, and this is a picture of a patient who has Gottron papules on the bottom left side of the screen here. Note the red scaly plaques and papules that you see on the back of the hands and the finger joints. It somewhat resembles psoriasis, and these are Gottron papules. And both of these findings are pathognomonic for dermatomyositis. That means if you have a patient with muscle weakness in these findings, you have a diagnosis of dermatomyositis. Some other skin findings in dermatomyositis are shown on this slide. First of all, patients with this disorder can develop a malar rash, just like patients with lupus. And you should be careful in board questions. Many people immediately think of lupus when they see a description of a malar rash, but that can also be seen in dermatomyositis. Two other signs you can see in this disorder are called Schall and V signs. These both happen for the same reasons. They are red-brown discolorations of the skin that occur in sun-exposed areas. When this occurs in the upper back, it looks like a shawl over the shoulders, and it's called the Schall sign. When it occurs in the neck and upper chest, it's called the V sign. That's because the chin blocks some of the sunlight and usually creates a small area with no rash, so the rash looks like a V, and that's called the V sign. And then finally, some patients with dermatomyositis develop what's known as mechanic's hands. These are cracks and fissures that occur on the palms, just like a mechanic might get. They have increased pigmentation, therefore there's darkening of the skin of the palm, and that's called mechanic's hands. I'll finish this video with this slide and mention that malignancies are associated with both of the inflammatory myopathies. The reason for this association is not clear, and there's stronger evidence for an association between dermatomyositis and malignancy than polymyositis, but nevertheless, both of the inflammatory myopathies are associated with an increased risk of malignancy. And the type of malignancies that occur are usually adenocarcinomas. So patients with these disorders can develop adenocarcinoma of the cervix, lung, ovaries, pancreas, bladder, stomach, and even some other organ systems. And you want to remember this for step 1. It commonly comes up on exams. And that concludes our video on muscle disorders.